classification and management. So for this class, the learning objectives will be the student should be able to know about how to restore the patient to optimal functional state and to prevent the fracture and soft tissue complication. As with the fracture, there should be the soft tissue complication. We have to avoid this by management and by knowing the fracture types and get the fracture to heal in a position which will produce optimal functional recovery, which is the main aim of our treatment method to achieve the optimal functional recovery. And in the last, we have to rehabilitate the patient as early as possible. These will be the things which will be included in this lecture. So, first of all, how will we define the fracture? The fracture is a soft tissue injury associated with break in the bone. This is the modified definition of the fracture, as the fracture cannot occur because without the soft tissue injury, either it is a minimal or a moderate or a massive soft tissue injury. So the definition has been modified in the form that the fracture is a soft tissue injury associated with the break in the bone. Excuse me, there's a problem. Let me solve it. How to yes. So next, the sign or symptoms of a fracture. What the patient will tell and what we will see in the patient of a fracture. So there will be the pain and tenderness at the fracture site. You can appreciate the tenderness. You cannot even touch the fracture site, and the loss of function. That patient cannot move that part, and a wound, either if it is an open fracture, there will be a wound which is communicating with the fracture, or deformity because of swelling, the fracture swelling, there will be the deformity. You will see the limb is in the abnormal position and unnatural movements and swelling and bruising, which is associated with the fracture. We can see these all things in the patient with the fracture. Why we classify the fracture? The purpose of classifying the fractures. Classification or description of fracture is useful in providing the aim will be that we have to treatment planning and communication between the doctors and how we communicate for the fracture, so that we have to classify the fracture and the outcomes. After the classification, we can identify which type of fracture has what outcomes. So that's why we classify the fracture. Different type of classifications are available: anatomic description, AO classification, Salter-Harris classification, Gustillo open fracture classification, and fracture specific classification according to the region of the bone which is involved. In anatomic classification, the description of location of fracture, we have to define the location of a fracture. That first of all, which bone is involved, either humerus, radius ulna, femur, tibia, which bone, and then which part of the third bone, whether proximal third, middle third, or distal third. Proximal, the upper portion, middle, the diaphyseal portion, or distal third of the bone, which part of the bone is involved. And then anatomic orientation, that is proximal, distal, medial, lateral, anterior, or posterior. And anatomic landmarks, which portion, like in the head, any part, head of the bone, or neck, body, or shaft, diaphysis, or base, or condyles. And segment. In the children's, we can say in the epiphyseal segment, physeal segment fracture, metaphyseal or diaphyseal fracture. So this is the location in which part of the bone, which location in the bone the fracture is present. But we have to identify first thing in the bone fracture. In the AO classification, the second classification for the communication purpose and like already described, for to know the treatment and know the outcomes of the bone fracture treatment. So we use the AO classification, which is first number, which describe the bone, long bone. Which long bone is that? Like I said, humerus, radius ulna, femur, tibia, and the second number, that the bone segment, either proximal, middle, or distal thread. And then there is a later fracture type, which is in the A, B, C. And then third and fourth number classify fracture group and subgroups. So I will elaborate further one by one in this. Like in this picture, 1 is for the humerus, and 2 is for the radius ulna, and 3 is for the femur, and 4 is for the first number, 4 is for the tibia. So the second number is for the anatomic location, that is proximal, diaphyseal, middle, or distal. Like in the humerus, you see 1 for the humerus, 1, and again the 1 number is for the proximal. 1, 2 is the 1 is the humerus, 2 is the diaphysis, and then 1, 3, 1 is the humerus, 3 is the distal part. Same in the 2 in the radius ulna, 2 is for the radius ulna, and 1 is the proximal, second is the middle diaphyseal portion, and third is the distal portion. Same 3 is femur, 1, 2, 3 again, and 4 is for the tibia fibula, and 1 is the proximal, 2 is the diaphyseal middle segment, and 3 is the distal portion. So these two numbers are according to the location of the bone, which part of which bone and which part of the bone. And then the letter is A, B, C. Either it's a simple fracture with 2 fragments, it's A. If it is a wedge fracture, it will be B. And then if it is complex fracture with no contact between main fragment, then it is type C. So after that, the second number, then the second this classification, then we have 8 in the simple fracture. If it is a type A fracture, either it is a spiral, oblique, or transverse. Then there again the number for the subgroup of the fracture. You can see that the 4 is for the tibia fibula, 2 is the diaphysis. Here in the spiral fracture, A is the simple fracture. In simple fracture, if it is spiral, it will be 1. If it is the oblique fracture, then it is the 2. If it is the transverse fracture, then it will be the 3. Here it is mentioned the oblique fracture is more than 30-degree angulation. And in the transverse fracture, it is less than 30-degree. So in the A subgroup, 3 is the transverse, 2 is the oblique, and 1 is the spiral. So for the wedge fracture, which is 2B, like 4, 2B, wedge fracture. And the wedge fracture, 1 is the spiral wedge, 2 is the bending wedge, 3 is the fragmented wedge. 4 is the tibia, 2 is the shaft diaphysis, B is the wedge fracture, 1 is the spiral wedge, 2 is the bending wedge, and 3 is the fragmented wedge. The wedge fracture which is fragmented is the B3. In the complex C, it is again 1, 2, 3, spiral multifragmentary, segmental fracture, and irregular fracture. Many fracture combination is there in the fracture. So it will be the irregular C3. So again in this 4, tibia, 2 is the diaphysis, C is the complex fracture. In complex fracture, 1 is spiral multifragmentary. You can appreciate in the picture, multi-fragments are there. And in the C2 is the segmented, that this segment of the bone from the tibia is isolated segment, that is C2. And then irregular, then the more combination is more, many pieces are there. So it will be the 4, 2, C3. And then after this, these were for the diaphyseal fracture, 2 fracture. The location of the bone will be the 2 diaphyseal fracture. And then metaphyseal fracture, either proximal or distal. Either it will be the extra-articular, which is in the metaphyseal region, but joint is not removed. It is outside the joint. So it will be extra-articular. And then partial articular fracture, some part of the fracture is communicating with the joint. So the partial articular. And complete articular, the fracture goes completely into the intra-articular region. It will be the C for the metaphyseal fractures. 4 is the tibia, 3 is the distal portion, A is the extra-articular, B is the partial articular, C is the complete articular. Then we can classify fracture according to the displacement of the fracture caused by force of injury, gravity or muscle pull. And to describe by translation, alignment, rotation and altered length. Always describe distal fragment into relation to the proximal fragment. We have to describe the distal fragment in relation to the proximal fragment for the displacement. Either it is translated medially, laterally, anteriorly, posteriorly, or its angulation, anterior angulation, posterior angulation, we will describe in relation to the distal fragment. So in the fracture displacement, we can describe the fracture, in which direction the fracture has gone, which is secondary to the muscle pull, gravity, or force of injury. Displacement translation. First, we have to see the translation. Translation is a sideway motion of the fracture, usually described as percentage of movement when compared to the diameter of the bone. In this picture, it is clearly seen that we have to describe the distal fragment. This is the proximal and this is the fracture, transfer type fracture, and the fracture is displaced, translated. And with what percentage it is, like we have to see the bone diameter in the picture. It is from here to here in this picture. And if it is 50% is diameter, this is displaced, translated. And then angulation. Angulation is the amount of bend at the fracture described in degrees. In translation, we will see the percentage. What sort of percentage the bone is, distal fragment is displaced, translated. And in angulation, it is in the degrees, respect to the apex of the angle, or with respect to the direction of the distal fragment. This is like angulation is of 30 degree, 40 degree, anterior or posterior, wherever the side the angulation is, in respect to the distal fragment. And then the shortening, that is the overlapping of the bone, the distal fragmented migrated. Shortening is the amount of fracture collapse expressed in centimeters, sometimes called Baynard opposition. The distal fragment is shortened, it goes up, and we calculate it in the centimeters. It's a 2 centimeter shortening is there. The distal fragment has displaced, shortening occur with 2 centimeter or whatever the amount is there. And then Salter had a classification which is for the used for the pediatric fractures that involve the growth plate, physis. There are 5 types from 1 to 5. In the Salter head classification, in the pediatric patient, in the type 1, it is the slip growth plate. There is a picture there. You can see the growth plate. This is the growth plate which can be slipped in the type 1. Type 2 is the fracture lies above the growth plate, that is in the metaphyseal region. And then the fracture is type 3, the fracture is lower than below the growth plate, epiphyseal fracture. And type 4, through. The fracture through the growth plate, including the metaphysis and epiphysis. This is type 4. In the picture, you can see clearly visible that fracture has crossed the epiphyseal region, metaphyseal region. This is through and through. So this will be the type 5 and type 4. Sorry, type 5 is a rammed. The growth plate has been rammed or run. The physis suffers a compression injury. Here it is a compression injury in the type 5. In the X-rays, you can see this radius ulna and this epiphysis, physis, metaphyseal region. If the fracture is in the epiphysis, you can say it's a or through and through, it's a type 4, or it is crushed, it will be type 5. The Gustillo classification. The Gustillo classification is used to classify open fractures in which the skin has been disturbed. 3 grades that try to quantify the amount of soft tissue damage associated with the fracture. Whenever there is a fracture, open fracture is when the fracture is communicating with the external environment. And we have to classify that according to the Gustillo classification. In Gustillo classification, there are 3 grades in open fractures. Grade 1 is the wound less than 1 centimeter with minimal soft tissue injury, and the wound bed is clean. there is a clean wound and one less than 1 centimeter wound, minimal soft tissue injury, and the bone injury is simple with minimal comminution, then it will be the grade 1 fracture. In grade 2 open fracture, wound is more than 1 centimeter with moderate soft tissue injury. The soft tissue injury will be moderate, and there will be the wound bed is moderately contaminated. There will be contamination of the wound, and the fracture contains moderate comminution. So it will be classified or graded as grade 2 open fracture according to Gustillo and Anderson. Then grade 3 is divided into 3A, 3B, 3C. 3A is when wound greater than 10 centimeter, crushed tissue contamination, soft tissue coverage of bone is usually possible. The 3A, the bone will be coverable with the soft tissue. In 3B, there will be the more than 10 centimeter, greater than 10 centimeter wound, the crushed tissue and contamination. Soft tissue is inadequate and requires a regional or free flap. The bone is exposed, and the soft tissue around it is not that much so that we can cover the wound, and we will need the regional flap or soft tissue coverage with other methods. So this will be the grade 3B. In grade 3C is a fracture in which there is a major vascular injury requiring repair for limb salvage. So in grade 3C, there will be the vascular injury. In some cases, it will be necessary to consider below knee amputation following tibia fracture. Because of vascular injury, which is, if it is irreparable, then it can lead to below knee amputation. Now, after all classification, we have to focus on the management. The management starts with the ATLS protocol guidelines with attention to the airway, breathing, circulation on presentation. The patient should be optimally resuscitated before any fracture treatment is considered. So the treatment of the patient with a fracture is starting. We have to follow the ATLS protocol. In ATLS protocol, we have to see the airway control, breathing, and circulation, and then we'll go for the fracture treatment after primary resuscitation of the patient. Treatment of fractures may be divided into 3 phases. One is the emergency care, second is the definitive treatment, and then we have to rehabilitate the patient, which is part of the rehabilitation, is the part of the management of the fracture. We have to consider this from the start of the treatment, then we have to rehabilitate the patient in the end. In an emergency, we have to apply the following principles in the emergency management of the fracture after ATLS protocol, that we have to align the fracture, the splintage, and analgesics. Analgesics to control the pain, alignment of the fracture, and we have to splint to decrease the patient's pain. Splinting is one of the most highly taught and least frequent of it. We don't focus much on this, but it has a very, we have to be focused on this splinting methods. Adequate splinting is desirable for the following reasons. Why do we do splint the patient after reduction? Because we have to decrease the further soft tissue injury, especially to the nerves and vessels, may be averted, and most importantly, closed fracture are saved from becoming open. If there is a fracture which is closed and it is angulated, translated, and creating pressure on the skin, so later on it can, if we do not do the splint after reduction, it can cause the closed fracture to open fracture. And after splinting, immobilization that can decrease the pain and relieves the pain of the patient. Splinting may well lower the incidence of clinical fat embolism and shock, because as we reduce the fracture and we apply the splint, then there will be the decrease the chance of the incidence of the clinical fat embolism and shock. And clearly that after splinting, the patient transportation and radiographic studies are facilitated. It will be easy because patient has got the patient's pain has been relieved. After that splinting in the emergency treatment, then we have to plan for the definitive management. The objective of the treatment of a fracture are to have bone heal in such a position that function and cosmesis of the extremity are unimpaired, and to return patients to their routine lives in the shortest possible time with the least expense. This is the principle we have to keep in the mind for the treatment of the patient for the definitive management. that we have to focus on the function and the cosmesis. We have to, by and doing any method of treatment, we have to keep this thing in the mind that we have to improve the function of the patient and then cosmesis. There are certain principles of fracture treatment after resuscitation. Following the Achilles protocol, we have to reduce the fracture. That is either open reduction or closed reduction. Open reduction means we have to open the fracture site and reduce the fracture. In closed reduction, we have to do the manipulation, traction and counter traction methods or gravity methods to reduce the fracture. And retention, then we have to do the splinting, either external splint, traction, internal splinting or external splinting. Depending upon the fracture type, classification, we have to do the splintage. And then soft tissue management. And in the final, as I already told, this is the main thing, that rehabilitation of the patient, which will increase the function and the cosmesis of the patient management. The reduction is the sooner the reduction of a fracture is attempted, the better, because delaying the reduction of the fracture can cause, as already mentioned, that closed fracture can turn into open fracture, or chances of fat embolism will be increased. So as soon as after resuscitation, we have to attempt for the reduction of the fracture. Before embarking on the manipulative reduction, adequate X-ray must be obtained to determine what the object of the manipulation are to be, or if needed, reduction is necessary. Because we have to identify the translation angulation of the fracture before going to reduction. We have to, keeping in this mind, we need X-rays. And X-rays, there are rules of two. Rules of two indicate that we have to do the joint above and joint below X-rays, and two views, AP and lateral, that we have to see any translation in both planes. In the reduction manipulation, we have to do methods, that closed methods, gravity method, or manipulation. In manipulation we can do the traction and counter traction method to reduce the fracture. Or if it is reduction is not possible with closed methods, we will go for the open methods, in which we have to open the fracture site. In closed reduction, indications are all minimally displaced fracture. Fracture that are minimally displaced, we can do the closed reduction. Most fractures in the children can be reduced closely. Fracture that are not unstable after the reduction and can be held in some form of splinter post can be treated closed reduction. Unstable fractures can also be reduced using closed method prior to stabilization with internal or external fixation. To achieve a reduction, the following steps usually are advised. These are the methods or steps we can follow to reduce the fracture. We have to apply the traction in the long axis of the bone. By doing traction in the long axis of the limb, we will achieve the reduction of that fracture. Or the other step is to reverse the mechanism that produces the fracture and align the fragment that can be controlled with the bone that cannot be. This is the most effective when the periosteum and the muscles on one side of the fracture remains intact. The soft tissue strip prevents over-reduction. This is the method we use in the closed reduction, that is traction in the long axis or reversing the mechanism that produces the fracture. And this can be most effective if the periosteum or muscle on one side is intact. So we can closely reduce the method in this type of cases. Here in the picture, it's seen that the one person is doing the counter traction and the other is doing the traction. And after traction, the fracture is reduced, then we will go for the next step, which is the splintage after reduction. Sometimes it's necessary to do the internal fixation after the fracture reduction. Or if it is not closed reduction is not possible, then we have to do the open reduction and internal fixation. The internal fixation, different methods are available for the internal fixation in the form of screws, plates, wires, transfixing, circlage wire, tension band wire, or intramedullary nails. These are the variety for the internal fixation. Biology and biomechanics. So for the internal fixation, mechanical stability, two types of stability are we have to achieve. Either we have to achieve the absolute stability or relative stability, depending upon the fracture. Again, here the classification will come in a mind that this type of fracture will need the absolute stability, or certain type of fracture which is good for the relative stability, and what the function we want to achieve. So in absolute stability, the principle is that it's defined as a rigid fixation that does not allow any micromotion between the fracture fragments under physiologic loading. The fixation which achieve this principle, that there is no any micromotion between the fracture fragments and physiologic loading, the fixation will be absolute stability. And in contrast to the relative stability, which allows limited motion at the fracture site under functional loading. Locked intermediate. These are the types which can fixation methods which can give the relative stability. In the locked intermediate layer, bridge plate or external fixator. This will give the relative stability. There will be the micro motion at the fracture site in the loading. In contrast, absolute stability does not allow any micro motion. In X-rays, there are certain pictures. First X-ray is the epiphyseal saltus fracture fixed with the leg screw. Second X-ray in the plating of the radius ulna. If it is applied in the compression mode, then there will be no micro motion and will give the absolute stability. Or if it is the fracture is fixed with the leg screw, will give the absolute stability. No micro motion will be at the fracture site. Or if we are doing any nailing, like K-wire nailing or intermediate nailing or brush nails, like in the X-rays, third X-rays, there is the right top X-ray. There is the intermediate fixation. There will be the micro motion at the fracture site. Or tibial nail is there, which can give the relative stability. Or any wire fixation will give the relative stability, like circlage wire, tension band wire. But if we apply the leg screw and then compression plating, that will give the absolute stability and no micro motion. Indication for the fractures that can be reduced except by operation, fractures that are inherently unstable and prone to redisplace after reduction, that is mid-shaft fracture of the forearm and some displaced ankle fracture, will go for the internal fixation. Fracture is liable to be pulled apart by muscle action, that is transfer fracture of the patella or oliferator by the pull of the muscle actions. So there, in these situations, we have to go for the internal fixation, because the muscle pull is that much that fracture can go apart. So we have to do the open reduction and internal fixation. And fracture that unite poorly and slowly, principally fractures of the femoral leg, where we already know that the fracture will unite slowly and poorly, and then chances of non-union are more. So in these situations, in this level of fracture femoral leg, we have to do the internal fixation. Pathological fracture in which bone disease may prevent healing will go for the internal fixation. Multiple fracture. Patient has got multiple fractures, polytrauma patient. We cannot go for the conservative management, because we have to do the early function, early recovery of the patient. So early fixation is needed in these cases. Fracture in patients who present nursing difficulties, paraplegic patients, those with multiple injuries, and the very elderly patients. Treatment of open fractures. As we know, after the classification of the open fractures, according to the Gustillo Anderson classification, then we have to plan for the management. In the treatment plan for open fracture, our aim will be to convert contaminated wound into a clean wound. That will be the first aim. That if it is a contaminated wound, we have to convert it into the clean wound. Then convert the open fracture into closed one. After soft tissue coverage, if it is needed, in the Gustillo 3B class, according to the Gustillo 3B or 3A, in which the bone is coverable. We have to convert it from open to close. To establish union in a good position, we have to align, reduce the patient, and to try to establish the union in a good position. To prevent pyogenic and clostridial infection, because it is open fracture, chances of infection are more, contamination are more. So we have to reduce the contamination and we have to clean the wound and to prevent the further any infection of pyogenic or clostridial. Order of priority will be patient, limb, wound, and fracture. First of all, we have to look at the patient after resuscitation ABC 8 protocol. So patient's life is important. Then the patient limb. After the 8 protocol, if all is okay, then the patient's limb is the priority. Then the wound, we have to manage the wound, and then fracture. 4 essentials of treatment: antibiotic prophylaxis, urgent wound and fracture debridement, stabilization of the fracture, early debridement, wound cover. These are the essentials of treatment. So we have to follow this. We have to start at least antibiotic prophylaxis, wound care, fracture stabilization, reduction, splintage, and debridement if wound is there, and then wound coverage to convert the open fracture into closed one. Sterility and antibiotic cover. In most cases, comarxamate or ciprofloxacin or clindamycin in cases of penicillin allergy is given as soon as possible. After we have to, in open fracture, we have to start the antibiotic prophylaxis. At time of debridement, gentamicin is added to a second dose of the first antibiotic. Wounds of Gustillo grade 1 fracture can be closed at the time of debridement. Antibiotic preference for up to 24 hours. This is very essential. We have to give the antibiotic coverage along with wound debridement and wound management and wound coverage. In grade 2 and 3A fractures, delayed closure after secondary look is sometimes preferred, because we have already seen that the open fracture, the wound was initially contaminated. We have done the debridement. So if it is coverable, wound is coverable, but we refer it to second look. After second look, if we feel that wound is better and there the contamination is decreased and wound can be closed, and then we have to cover the bone with wound closure, that is in the delayed closure. Grade 3B and 3C, delayed cover is usually practiced. In 3B, when there is a massive contamination, and 3C, when there is a vascular injury which required the repair, so there is a wound, better it's covered delayed. Total period of antibiotics up to 72 hours. This is the antibiotic prophylaxis in the open fracture 3B, 3C. 72 hours we have to give the antibiotics, and then second look of the wound. In open fracture, the debridement is necessary. The first step, that is a thorough irrigation of the wound with copious amount of normal saline to remove all foreign materials in the wound, followed by excision of dead tissue. This is the basic principle of the wound debridement, which is starting from the thorough irrigation of the wound. As much as normal saline we can use, up to 10 liters, we have to wash the wound to remove any foreign body, any foreign material, any dust, any particles, and then along with, which is the part of the debridement, that excision of all dead tissue. In the dead tissues, you can find if muscles are dead, you have to remove that muscles. If the subcutaneous tissues which are dead, you have to remove that. If bony fragment which seems to be dead or which is detached, it can be excised. So excision of all dead tissue is the part of this debridement. Tourniquet may be used to provide bloodless field, but it can cause ischemia and make it difficult to identify devitalized strictures. Principle observed during debridement, that wound margin excision. If we see in the wound debridement, the margins of the wound are dead, we have to excise all the margins. Wound can be extended to know the demarcation and the diseased portion. Delivery of the fracture, we have to open the fracture, we have to see the margins of the fracture, removal of the devitalized tissue, and wound cleaning. Uncontaminated wound in grade 1 or 2 can be sutured. If we see the wounds are clean, so and grade 1 or 2, the wound can be primarily sutured. Second come after the wound debridement, the fracture stabilization in the open fracture. Important in reducing risk of infection and assisting recovery of soft tissue. So if we do after debridement, decrease the risk of infection and to heal the soft tissue early, which will assist in the soft tissue injury healing, we have to stabilize the fracture. Different methods of fixation depends on degree of contamination, length of time from injury to operation, and extent of soft tissue damage. These three things which we keep in mind, and then we will plan for the fixation method depending upon the contamination and the time from the injury to the operation and the soft tissue damage. If there is no contamination, definitive wound cover can be achieved at the time of debridement. All open fracture can be treated as a closed injury. Can be treated with closed injury like the closed methods of treatment. Internal fixation or external fixation may be appropriate depending on the individual characteristics of the fracture and wound. If wound cover is delayed, then external fixation is safer. However, fixator pin should be inserted away from the potential flares. This is the method of either we will go for the internal fixation or external fixation. If wound is contaminated, wound is not clean, which will lead further debridement, then we go for the external fixator. We cannot go for the internal fixation in this type of contaminated wound. Internal fixation can be used at the time of definitive wound cover as long as delay to wound cover is less than 7 days. So these are the things that if there is no visible contamination, internal fixation can be done. Internal fixation can control the fracture as well as the external fixator. Stabilization of the open fracture, plaster immobilization, pins and plaster, skeletal traction, external fixation, internal fixation, hybrid fixation. These are the different methods which can be applied for the stabilization of open fracture after the wound debridement. These all methods depends upon the degree of contamination in the wound, soft tissue coverage. We have to choose the one method from this type of stabilization for after regulating the wound. Thank you very much. Any question regarding this? My chat box is open. There is one question regarding AO classification. This classification. This is AO classification. There is a question for AO classification. In the AO classification, there are first the two numbers. First number is the long bone, and the second number is the bone segment. And then is the letter like A, B, C, which will define the fracture type. And then third and fourth numbers will classify the fracture group and subgroup. There is in the picture, if you see clearly, there are two numbers. First bone is the humerus bone on the left side. Number 1 is for the humerus. go to the second picture, you see number 2 is the radius ulna. Next picture, femur, which is femur. The third number 3 is the for the femur, 4 for the tibia. Now again come to the left picture. The second number is 1 is for the proximal, 2 for the diaphysis, and 3 for the distal femur. Same in the 2 for the radius ulna, 1 for the proximal, 2 for the diaphysis, and 3 for the distal femur. But so the 2 numbers will be for the location of the bone, and then the later will identify the fracture type like A, B, C. If it is simple, then it will be the simple fracture with 2 fragments. If it is the wedge fracture, then it will be type B. If it is the complex fracture, then it will be the type C. So the third thing is the letter, which will be the type of the fracture. In the subgroup, like spiral, will be applied for the AO classification for the another question is there, the screw can be taken out after the fracture beneath. Yes, there is the protocol for the removal of metal, removal of screw or plate or internal nail, which type of fixation is there. And after the bone has healed, the screw should be removed. Like in the lower limb, it should be more than 18 months to remove the implant, or in the upper limb, after the 1 year, the implant can be removed. This is clear for the AO classification, and the other question, the removal of implant, the removal of screws. Any other question? So up till now, the classification and management options for the open and closed fractures, different type of fixations, and methods of fixations are clear now. We have gone through the principles of fracture management. I think it's clear now, and wish you all the best. Take care in this COVID situation. Take care of your family, yourself.